Okay. Good afternoon to all the panel, the audience. I think we have a technical. If you can fix it. And speak. Okay, how are you?
Okay, thank you, Professor Angate, for this nice presentation. My talk today will be on this interesting topic, I think, which is the project of building a surgical database for our association. I think this comes out after several discussions we had during our periodical webinars. We had a lot of exchanges among local cardiovascular specialists, but also we had some experts who share with us their experience in managing cardiovascular disease in our continent. So thank you again, Professor Angate, for giving us a very short, I hope, but interesting topic to our community. Can you lead the slide that was before?
Okay. Can we have the slide? Or you leave, I can do myself. I'm not sharing anymore, so you can do it. Okay, so I was saying that my presentation will be
on the project of building a surgical database for our association. Next slide, please. I will prepare it possible that I do it myself from here. So we stop everything from there, share my screen. So if I share it, we'll do it myself, please. Okay. So I was saying that this talk is about building the African database. In Africa is very complex, and we all know that cardiovascular disease over the past decades in terms of prevalence have been growing. More than 3/4 of the deaths which are attributed taking place in Congo. We had more than 50% increase of cardiovascular deaths in Sub-Saharan Africa over the last 3 decades. Of course, being in the area with young population, the majority of these deaths are occurring in young people. This is mainly attributed to the rise in risk factors. Of course, we all know how uncontrolled hypertension is increasing in our context, with the high prevalence in young people with severe consequences, as those we know from stroke to ischemic heart disease. We are leading also in the area where we have a lot of problem arising from acute rheumatic fever and rheumatic heart disease. I think everybody working in a cardiosurgical department in this room have faced at least once during this activity how it's challenging managing these young people with rheumatic valve disease. We are a young continent, so we have a lot of, as I early said, a lot of young people. And this leads to a situation where we have the high number of children born with congenital heart disease, which in certain situation is 3 times what we are observing in other areas. We have, I don't have particular areas, but if you look at the literature, we have serious complications arriving from some neglected diseases, especially HIV, where we have a lot of publication on vasculopathies and this particular pattern of myocardial disease, which is the endomyocardial fibrosis, which are situation you will have to deal with when you start working in our area. Unfortunately, all this happen in a context where we have a sufficient number of specialists and institutions. This is a paper published, let's say, 9 years ago, but the situation has not changed too much since that time. Even when we recognize that in the global area of Africa, there are regions where you have better, it's okay. You have better ratio. The situation is still under what is observed in the rest of the world. It's okay, thank you. We talk about number of centers. Sometimes we think that the number of centers means that the needs are met in these countries. We have a lot of cardiac centers available, but when you look closely, if those centers have some epidemiological impact, you will just think that, of course, more is still to be done, because majority of the existing centers are still low volume institutions. We are in some cases we are covering less than 2% of what is representing the cardiac disease on this area. Another consequences is that if you have low activity, it's not always the same, but most of the case, the less you do, less you can be involved in some consistent research. This paper published what has been the publication in cardiac surgery over the last 2 decades. Of course, you can see in red some of the countries where you have a lot of surgical activity, has been also those who are producing consistent publications. This is more global to say, hey, it's not only a matter of cardiac surgery, it's the whole cardiovascular research in Africa over the last 50 years. You have seen how the global situation rise, even though there has been some improvement in the quantity of publication from the sub-Saharan area, it's not that significant. So we are relatively producing less than what we are supposed to do. And one of the reasons has been because there is a lack of collaborative research in the area. You can find now some of our colleagues, the cardiologists, are doing a lot of multi-center studies and so on, but it's difficult to find some multi-institutions study on cardiac surgery. So we have to look deep into that. So to some situation in our context is to be found in three different aspects. The first, of course, prevention, diagnosis, and therapy. And the third one is the scientific research. In prevention, we are not like the face, because, you know, the education, there are some public policies to be put in for the therapy. You have other specialties. But in scientific research, I think it's important that the surgeons start playing an important role, an important and dynamic role. What can a CT association from Africa do? Of course, our objective is we are here to improve the quality of care in our population having cardiac disease. We have to be more involved in scientific research. We have to report what we are doing to the community, because in several occasions, when we were exchanging during one last webinar, we have our Egyptian friends doing more TGAs than in many European countries, but nobody knows that. So they are doing, in certain cases, 120, 140 TGAs per year. So this is high volume institution. If you are an African and you will have to improve yourself in complex congenital surgery, you may find a solution locally. What have we done at the level of the association? Since 2021, we start some discussions. It's true that this happened in the middle of the pandemic, so we had just these virtual interactions to be made, but we create what is called the African University for Thoracic and Cardiovascular Surgery, which is a virtual platform always under the roof of the main association. But with this platform, we intend to organize some scientific exchanges and see how we can build some common projects, scientific projects. These are some of the participants from many countries, also from some Western countries will share their experience with us. And the main lessons from this, we were already suspecting that something might be wrong, but that what we are doing in our small, low volume institutions is not that bad at all. When you take some specific areas, some of the mortality rate, the morbidity rates are not that bad at all. So if you have to take the results from 2010, from 2023, there have been a great improvement. But unfortunately, we are still having a lack of communication of what we are doing. So we have to have a more aggressive policy concerning this. And of course, there is a huge absence of collaborative projects, especially at the scientific level. And then it's also the role of the association to create that dynamic to impact this scientific activity. So one of the topics we had at that time was we should build a database. The database will be, to some extent, like a way to create a strong collaborative network on which we are going to research, and this can be also a major tool for quality improvement. And as we have seen in other realities like the STS, the EX, and so on, in future, when we have enough data, consistent data, quality data, we'll be able to build some risk stratifications model. That will be specific to our population. Most of the time in acquired heart disease, when you have to do a complex case, you go STS score and you try to see, but this is built on a population which is different from what you are intending to treat. So it might be more appropriate to have risk stratification model built on the population we are having on the continent. Of course, have a database is not just a matter of saying, hi guys, send me the data, we are going to write a nice paper. To some extent, it can be expensive. when you look at what they have done at the STS and what is cost, you need to have strong support to go inside that, because you need some data manager who are taking care of the software, who are taking care of the safety of the data. There are also legal issues, also the audit part of it, because for instance, what is happening in the STS is that every year, like 10% of the sample are checked. So to give some credibility to that existing database. So what have we done? We try to report and do a small pilot study. This pilot study was made in 2 institutions, which are with regard to the type of populations which are similar in Ivory Coast and in Cameroon. 2 countries where cardiac surgery has a long history. We are talking 2023, but when you closely look when things started in these 2 countries, we have passed 3 decades. But unfortunately, as it used to happen in our populations, in our realities, things started and then start, and we lose, for this reason, a lot of activity. The situation in the 2 countries is currently this one. The participating center that were involved. What have we decided to do? We try to simplify data collection and analysis, just selecting some isolate or not complex procedure in cardiac and thoracic. But my talk will be focused essentially cardiac. So in acquired and congenital heart disease. We identify some major procedures, mitral valve surgery as the commonest procedure, aortic valve replacement, double valve replacement, aortic and mitral, and on the congenital part, we just focus on 2 main procedures. The variable that we took into considerations were simple, just the age of the patient, gender, and the early outcomes. Of course, in our reality, you can imagine how the follow-up might be not easy. We involve both in retrospective and prospective data. We send some model, unique model for data compilation, and we use some simple software. To be more rigorous with ourselves, because we have to be autocritic is what we are doing. To some extent, looking at the data in all what we have seen, there were some area where we didn't have complete informations, but we did extrapolate from what was available. So to summarize, we took 200 and almost 2,000 and almost 400 patients, both in acquired and congenital, as you can see. Taking the informations, you can see how the age at surgery, if you have to start comparing this with the reality in the Western country, our patients in acquired are relatively long, our patient with valvular heart disease. When you go at the STS or the EX, these are patients you are operating not so early. They are above 50 of mean age. And for congenital, of course, there's late diagnosis of congenital heart defects. So patients treated in our reality are often older than what is in Europe, for instance. These are the sex ratio in the acquired heart disease, more female than male. When you take simply some isolate procedures, we reported this mortality, which is 4.5%. I have to remember that all those data were taken in different time of the evolution of each program. So their mortality reported from 2009, some even in different phases, this has changed. And this is definitely not the mean value of the operative mortality for this procedure that we are having in our institutions. Mitral valve surgery, this is the same. And one important information we can get from here is how many of these patients with mitral valve disease, since they are almost all young people, are benefiting of repair. Because we know repair in the context of rheumatic disease is always challenging. Not always in terms of feasibility when the surgeon is taking the patient to the OR, but also on the long term, because the rate of recurrence used to be high. So some surgeons are more reluctant to try a repair because the risk of reoperation sometimes may be high. But this gives us that despite all this situation, there is some tendency, above 32% of the patients who are undergoing mitral repair. It's a result from double valve replacement. And when you try, I think there's small error in the mortality, but I think we can after correct it. When we try to compare what is our reality with or what is in the database from the SDS and AAPCHS, of course, we are comparing apple and bananas, apple and orange. They are different populations, but at least this can give you an idea of what is currently done. For instance, for mitral valve surgery, we are not that far from what used to be the outcome in terms of early mortality in patients undergoing mitral valve surgery in these countries. For the congenital, these are for some PSD repair. Which type of DSDs? Those are information related to TOF repair. Some comparison with what is reported in the SDS database. So of course, we have several limitations to do this. First, this is not a good sample for registry, but as is early said, it's a pilot study. So you need to see, and before you can go into something bigger. Of course, we had some low completeness of having some variables. Also were mostly retrospective. The fact that the institution didn't have the same way of recording the data could have bring some not proper reliability. So the situation in our continent is not good at all. We are still lacking a lot of policies which are not effective in terms of prevention and therapeutic management. But it's our duty, it's our responsibility, mainly as an association, to build a strong surgical community in order to gradually, block by block, build some important network to improve our scientific research. What should we do now? Because after all this discussion, we have to find a way to have more participants to this database. And the second point is that we have to affinate, we have to make very consistent and very accurate the way we are reporting the data, giving more importance to quality rather than quantity sometimes. This is also important for our credibility. And from 2024, every December, I think we are intending to publish some update of this database to see then the evolutions. And another point where we have to work on will be to have some strong partnerships in terms of data manager. This is how the other associations are doing. Someone is in charge of the software, and then a doctor from Burkina, Mali, Cameroon, Ivory Coast in his home just have to assess, fill the data, and somebody is going to analyze and give those informations at the end of the year. And also do some external audit, because if we want to sell and bracket ourselves to the whole global community, we need to be credible, we need to be reliable in what we are reporting. So thank you for your attention. I leave you with this small quote of this American author. We said, if you have to change the world, of course, we are just talking about database, but you can project yourself in the whole thing. You have to change the place where you are first. So it's a block by block process, and I hope we are all inside that vision. Thank you for your attention.
We'll take the second presentation of the topic, registry in Nigeria. And after that, we'll have some comments.